morning. I want to thank the organizers for inviting me and for your attendance to my talk, Controversies and Consensus in Mesothelioma Care. Here you can see my disclosures for the past 3 years. I will begin by covering some basic information about mesothelioma and then launch right into a discussion of several controversies regarding disease management. First, let's briefly review the presentation and diagnosis of pleural mesothelioma. As you know, most patients present with a recurrent ipsilateral pleural effusion. Often cytology of this fluid is bland or non-diagnostic. Imaging can also be subtle with minimal pleural thickening, as in the panel on the bottom right, or more dramatic with bulky disease, as in the panel on the upper left. Usually a surgical biopsy is necessary to make a firm diagnosis. Distant metastatic disease at diagnosis is uncommon, but does occur, and a PET is standard to be obtained at the time of diagnosis. WT1 and calretinin are key IHC markers to help differentiate between metastatic adenocarcinoma and mesothelioma. There are 3 subtypes of mesothelioma: epithelioid, which is the most common and most responsive to chemotherapy, sarcomatoid, and biphasic, which is a combination of epithelioid and sarcomatoid. As you probably know, mesothelioma has its own staging guidelines. While there are similarities with the lung cancer staging system, it is important to note that the classification of N1 and N2 lymph nodes is different, as the pleura drains differently than the lung parenchyma. Additionally, the T staging is dependent on the depth of invasion of the pleural malignancy. And that's often difficult to accurately assess prior to resection. As with other diseases, the TNM staging combines together for a numerical stage. Stages 1 through 3A are potentially resectable. Stages 3B and 4 are unresectable. When I was thinking about consensus and controversies in preparation for this talk, I really could only identify one truly non-controversial aspect of mesothelioma care, and that's really the cytotoxic chemotherapy regimen. In the landmark randomized phase 3 emphasis trial, treatment-naive patients with unresectable mesothelioma were randomized to receive either cisplatin or cisplatin and pemetrexed. Median overall survival was modestly improved with the combination of cisplatin and pemetrexed to 12.1 months as compared to 9.3 months with cisplatin alone. This led to the FDA approval of this regimen in 2004, and until last year, or 2020 in the fall, it was the only FDA-approved regimen. And that's really it. That's the one thing that I think internationally there's strong consensus around. But now there are a bunch of controversies, and they're really interesting to dig into. Let's start with a discussion about the role of surgery. For a long time, extrapleural pneumonectomy, which involves the en bloc resection of the ipsilateral lung and pleura, was long thought to be the only potentially curative surgery for pleural mesothelioma. However, it is associated with high morbidity and mortality. Pleurectomy decortication, a less dangerous surgery in which any uninvolved lung tissue is spared, was reserved for patients who were thought too high risk for a pneumonectomy. This was felt to be a much inferior surgery in terms of oncologic outcomes. Yet in 2007, a multi-center analysis, you can see here the survival curves from that analysis, showed that long-term survival was actually superior with pleurectomy decortication as opposed to pneumonectomy. Since then, there has been a shift away from pneumonectomies. The surgical consensus in the US is that we should perform the least amount of surgery to achieve a macroscopic complete resection. Around the world, though, the role and value of any surgery in the treatment of pleural mesothelioma remains controversial. For example, in the UK, the MARS-2 randomized trial is ongoing and compares pleurectomy decortication to no surgery at all. I think those results, when they're shared publicly, will likely influence and shape practice globally. Since the emphasis trial, several studies have sought to add agents onto the combination of cisplatin and pemetrexed. One particularly active area has been around the role of anti-angiogenic agents. In the French MAPS trial, treatment-naive patients with unresectable malignant pleural mesothelioma were randomized to receive cisplatin and pemetrexed versus cisplatin, pemetrexed, and bevacizumab. As you can see in the Kaplan-Meier survival curves, there was a small but statistically significant improvement in overall survival. Median overall survival with the triplet combination was 18.8 months and 16.1 months with doublet therapy. This led to inclusion of this regimen in the mesothelioma NCCN guidelines. However, the regimen is not FDA approved and not used in some countries, especially where cost-benefit calculations factor into coverage. In my own practice, unless someone has contraindications to bevacizumab or their performance status precludes the use of triplet therapy, I try to use bevacizumab with pemetrexed and platinum treatment. What is also interesting to note in this and multiple other recent studies is that survival is consistently improved in the control arm of cisplatin and pemetrexed compared to the initial Vogelsang study. We do not know if that is because of better supportive care, earlier diagnosis, or better emerging subsequent lines of therapy, but it is important to note, and it makes historical comparisons of various regimens very complicated. The most recent and perhaps most biologically intriguing controversy is whether to use chemotherapy or immunotherapy as the initial systemic treatment regimen. Here you can see the study schema for the Checkmate 743 trial. In this study, treatment-naive patients with unresectable disease and good performance status were randomized to receive platinum and pemetrexed for 6 cycles or ipilimumab and nivolumab for up to 2 years. As you can see here in these Kaplan-Meier curves, this was a positive trial. Median overall survival was 14.1 months with chemotherapy and 18.1 months with immunotherapy. Based on these data, the FDA approved ipilimumab and nivolumab as an initial treatment for all types of unresectable pleural mesothelioma. But really, with this trial, the devil's in the details. In a pre-specified analysis by histology, for which the randomization was stratified, you can see marked improvement in overall survival among those with non-epithelioid disease. For non-epithelioid disease, median overall survival with chemotherapy was 8.8 months compared to 18.1 months with ipilimumab and nivolumab. However, with epithelioid disease, the most common subtype, median overall survival with chemotherapy was 16.5 months and 18.7 with immunotherapy. And the hazard ratio for this crosses 1. So really, I think based on histology, we can say that immunotherapy and chemotherapy are roughly equivalent. But I think it's hard to say that one treatment is better than the other. I think it's also important to note that bevacizumab was not an option in the control arm. And that might have made the chemotherapy arm even a little better than it did perform. There was also an analysis by PD-L1 status, which revealed that those with PD-L1 positive tumors derived most of the benefit of immunotherapy. For PD-L1 positive tumors, median overall survival with chemotherapy was 13.3 months and 18 months with immunotherapy. For PD-L1 negative tumors, however, median overall survival with chemotherapy was 16.5 months and 17.3 months with immunotherapy. And again, the hazard ratio for that crosses 1. These data clearly support the routine use of ipilimumab and nivolumab as initial treatment for sarcomatoid and biphasic mesothelioma. Yet great controversy around the management of epithelioid disease remains. Additionally, in data not shown this morning, the progression-free survival curves cross for epithelioid disease, indicating that the initial progression-free survival for these patients is worse with immunotherapy. In my own clinical practice, this is a very individualized decision considering patient preference, disease burden, and ability to tolerate potentially initial progression before a response. I do have a slight preference for cytotoxic therapy, especially if a patient is eligible for a triplet combination with bevacizumab in my patients with PD-L1 negative epithelioid disease. It's important, as I mentioned before, to remember that the control arm in the Checkmate 743 trial did not include bevacizumab in the cytotoxic regimen. So it may be underreporting the effectiveness of chemo if you're going to be using triplet chemotherapy. When considering this clinical decision, it is also important to remember the increased toxicity associated with immunotherapy, including more than twice as many treatment-related deaths. Many patients mistakenly assume that immunotherapy is less toxic than chemotherapy, but the data do not support this conclusion. In order to provide some clarity in this confusing new space, the NCCN guidelines include both cytotoxic chemotherapy and dual immune checkpoint inhibitor therapy as first-line treatment options. But there is a footnote, which I highlighted here in red, indicating that immunotherapy is preferred for non-epithelioid histology. As you may know, there are 2 ongoing randomized phase 3 trials of chemotherapy immunotherapy combinations. Phase 2 data for these combinations appears promising, and the phase 3 results are eagerly anticipated. It's important to note that the control arms in these trials are chemotherapy alone and not dual agent immunotherapy. So we will learn whether chemo IO is better than chemo, but not if chemo IO is better than dual IO. When these results are available, we may have an additional treatment option that is especially appealing for those with epithelioid disease. But as many questions as we answer, there's always new ones and more. The final controversy I will discuss is what to do for second-line therapy. In light of the recent approval of immunotherapy as an initial treatment option, this question has been reinvigorated. Most experts agree that those who receive chemo frontline should get immunotherapy second line and vice versa. The data regarding other cytotoxic agents is limited and mostly from before the routine use of pemetrexed. In our own institutional experience shown here, among patients who previously received pemetrexed-based therapy, there was a low response rate, less than 5%, with vinorelbine and gemcitabine, which are the most used agents in this setting. A substantial fraction of patients, about 50%, do achieve stable disease, but it is short-lived for a median of only 6 weeks. More recently, the RAIN study randomized patients with mesothelioma who had previously been treated with platinum and pemetrexed. The 2 arms were gemcitabine and gemcitabine with ramucirumab, another anti-angiogenic agent. Key eligibility criteria included no prior bevacizumab and having received only 1 prior line of treatment. Randomization was stratified by ECOG 0, 1 versus 2 age greater than or equal to 70, age less than or equal to 70 versus greater than 70, histological subtype, and time to progression on the initial line of treatment. As you can see here, there was a statistically significant improvement in overall survival among those who received combination therapy. But what is interesting to note is that at the end, far out in the 24 to 30 month range, that the curves do converge. Median overall survival with the gem-ram arm was 13.8 months versus 7.5 months with gemcitabine alone. It remains very unclear how this will integrate into the treatment paradigm with the recent frontline immunotherapy approval and the routine use of bevacizumab in some countries. This combination is not FDA approved and it is not yet included in the NCCN guidelines. Personally, I consider this data compelling, and in a patient in whom I would be considering gemcitabine, especially if they haven't received a prior anti-angiogenic agent, I would definitely consider the addition of ramucirumab. But it's hard to quantify what that value and what that improvement will be for any particular patient. Also, increasingly, even in patients who receive first-line chemotherapy for, let's say, PD-L1 negative epithelioid disease, often in the second-line setting, they will then receive dual immunotherapy or single-agent immunotherapy. And we don't know if that impacts the efficacy of this regimen. In summary, I hope I have given you a glimpse of the current standards of care and some ongoing controversies in the treatment of mesothelioma. There is broad consensus that pemetrexed-based chemotherapy is the standard cytotoxic regimen. The role and value of surgery remains an active topic of discussion at mesothelioma meetings, and hopefully the ongoing MARS-2 trial will bring some further data into that space to help clarify those decisions about what the value of surgery is, who should get it, and when it should be used. I talked to you about the modest survival advantage associated with bevacizumab, but its uptake and use is not universal. It's very high in the US and in France, where the trial was initially done, but not so much in other places around the world. We also talked about how to use immunotherapy and how to integrate the Checkmate 743 results into clinical practice. I know that most experts agree that it's clearly the right treatment, IO, for sarcomatoid and biphasic disease, but a lot of ongoing discussion surrounds what to do with the epithelioid patients. And hopefully the chemo IO trials will bring yet another option for those folks where they still get the benefit of chemotherapy, but also have the potential impact of an immunotherapy option integrated into that. And then we talked about gemcitabine ramucirumab as an emerging second-line option. Without integration either into the NCCN guidelines or FDA approval, I don't think in the US or my practice there'll be significant use of that. But I'm not sure that that makes it necessarily a bad option. I think the data is not as robust for it in this space, and this space has already changed. By the time this trial was done, second line had already shifted because of the new frontline approvals. So again, in my clinical practice, if someone is gemcitabine eligible, I think about adding the ramucirumab, especially if they haven't previously received bevacizumab. This is really a time of great activity and investigation in mesothelioma, and I expect the field to continue to evolve rapidly over the coming years. I'm really delighted to be able to share my perspective and some of these issues with you this morning. And thank you again for the opportunity to speak at your conference.
Thank you so much for enlightening us on that topic of consensus and controversies. I think it was an excellent overview of most of the things what we see in clinical practice. In the chat box, I could see a question about your experience with peritoneal mesotheliomas.
Yes. So, generally speaking, peritoneal mesotheliomas tend to be more epithelioid. Um, there are, as you know, many less trials dedicated just to peritoneal, but there are small studies that validate the use of chemotherapy combinations as well as immunotherapy. And then there are some independent immunotherapy trials in peritoneal. For example, there was recently a study of atezolizumab and bevacizumab for peritoneal disease as a second line or beyond therapy. So the treatment is systemic regimens are relatively similar, but there's just a lot less sarcomatoid or biphasic disease in the abdomen.
What's your take on HIPEC in this situation?
It's a great question and super controversial and really varies by institution. We don't do HIPEC at MSK, but we do EPIC. So we do early post-op intraperitoneal chemo. I think when, you're comparing different single institution or small studies between them, but I think that chemo into the abdomen is important. I think it's less important whether it's HIPEC or it's EPIC, but getting some disease, some treatment into the abdomen, I think is really important in that disease.
Another question, I think, which most of us practice here in India is with the patients with the poor ECOG or in the third line or fourth line, role of metronomic chemotherapy in these patients.
Yeah, I think that's always a challenge, and a lot of times, that's what we're doing in poor performance status patients who still want some kind of therapy. But as again, as you guys know, there's no strong data for it, but it's just something that winds up being done. There sadly are not really prospective trials of poor performance meso patients.
I think one important point you brought up is the comparison of IO versus chemo, where there was no BEV in the protocol. So I think we need to look into the depth of the studies instead of just taking over the data. Maybe we don't know if BEV is added, whether IO still has an upper arm. So I think if there are no more questions in the chat box, I again thank our speaker for that excellent talk and giving an excellent overview of mesothelioma. So we are very clear about what to do with the Monday morning patients if he comes with a mesothelioma. Thank you so much.
Thank you.
So thank you very much. And indeed, Marjorie, thanks a lot. And to bring into everybody's notice that she has recent COVID and was actually very sick. Her voice is still having reflections of that recent COVID, which she's recovering. But instead, in spite of that, she joined us and delivered this great talk. So thanks again, Marjorie, and thank you very much, our esteemed chairpersons, Dr. Parekh and Dr. Shailesh, to really manage this superb in a manner. So I will move on to the next session and hand over the mic to Amay again.